Usually when we think about surgery, the image that comes to mind is just incredibly loud.
Oh, absolutely.
It's monitors beeping, oscillating bone saws, massive retractors, pulling tissue apart, these really large, dramatic incisions.
Yeah, the sheer macro level trauma of it all is what most people envision. I mean, in traditional open surgery, the process is highly visible.
Right.
And the goal is often just, getting in, fixing the primary structural issue, and getting out, sometimes regardless of what the surface actually looks like afterward.
But then you step into the world of dermatologic surgery, and that whole paradigm just completely shifts.
It really does.
Dermatologic surgery isn't just about, making cuts to remove a problem. It is this high-stakes, microscopic dance of anatomy, biomechanics, and, well, absolute artistry.
That's a great way to put it.
The ultimate goal in so many of these cases is to leave absolutely no trace behind, like you were never even there.
It really is the pinnacle of surgical camouflage. And to achieve that invisibility, the surgeon has to understand the medium they are working in with just staggering precision. I mean, the tolerances for error are literally measured in millimeters.
Which brings us to our mission for you today. Welcome to this deep dive. Today, we are cracking open the definitive text on this subject, Requisites in Dermatology, to look at what actually happens when the scalpel meets the skin.
It's a fantastic resource.
We are cutting through the dense jargon to give you the high-yield science and practical applications that actually matter. So whether you are a medical student prepping for boards, a young professional refining your technique, or just, an insanely curious learner, we're exploring the physiological rules of this incredible field.
And to truly grasp the surgery, we must first understand the canvas. The human skin isn't just a uniform covering. It's a complex, highly varied landscape.
Right, it's not just one sheet of tissue.
Exactly. You cannot reconstruct a defect if you don't fundamentally understand the topographic and structural rules that govern the face and neck.
Okay, let's unpack this. Before a surgeon even picks up a blade, they are essentially mapping the terrain. But think about the practical challenges.
Well, there are many.
Like, if you have to numb a significant portion of a patient's face for a large excision, how do you avoid just flooding the tissue with local anesthetic? Because, injecting huge volumes of fluid would completely distort the very canvas you're trying to carefully cut and reconstruct.
That is a major logistical hurdle, actually. And the solution lies in a specific anatomical coordinate system. Surgeons rely heavily on what is called the mid-pupillary line.
Mid-pupillary line, okay.
Yeah. So if you visualize a vertical line running straight down from the middle of your pupil, which sits roughly 2.5 centimeters lateral to the midline of your face, you will find 3 major anatomical landmarks perfectly aligned on that axis.
Wow, that feels like a secret architectural blueprint built right into the skull.
It acts exactly like one. On that vertical line, you have the supraorbital foramen just above the eye, the infraorbital foramen just below the eye, and the mental foramen down on the jaw.
And those are just holes in the bone, right?
Right. They are the bony exit points for the key sensory nerves of the face. So by knowing exactly where they are, a surgeon can safely administer targeted nerve blocks.
Oh, I see.
They deposit a small amount of anesthetic right at the exit hole, effectively numbing entire regions of the face without having to inject directly into a sensitive surgical site. It preserves the normal tissue architecture.
That makes so much sense. That topographical map goes well beyond just bones and nerves, though. The textbook emphasizes the concepts of cosmetic units and contour lines.
Yes, absolutely.
This seems to be where the clinical science really blends into visual artistry.
The visual mapping is crucial. The face isn't treated as one continuous sheet. It is divided into distinct aesthetic regions like the forehead, the nose, the chin, the cheek.
And those are the cosmetic units.
Exactly. And they are separated by contour lines. The underlying biology dictates that skin texture, thickness, sebaceous gland density, and color all remain remarkably consistent within a single cosmetic unit.
But they change the second you cross that line.
Right. They change dramatically the second you cross a contour line.
So, like, the thick, oily, porous skin of the nose is a completely different neighborhood than the paper-thin, delicate skin of the eyelid right next to it.
A completely different cellular environment. And the golden rule derived from this anatomy is that crossing these contour lines with a surgical incision will inevitably draw the human eye and distort the face.
Because it disrupts the natural borders?
Precisely. To hide a scar, a masterful surgeon will place their incisions directly along these natural borders, Furthermore, they align their cuts with relaxed skin tension lines, or
Well,
STLs.
this concept. If you pinch your skin or observe the natural wrinkles that form when you smile or frown, you're seeing those STLs in action. I like to think of aligning with STLs as cutting with the grain of wood rather than against it.
That's a perfect analogy.
If you cut with the grain, things sit flush and natural. But what is actually happening beneath the surface to create that grain?
Well, the biomechanical reason for this involves the underlying musculature and the dermal matrix. STLs generally run perpendicular to the underlying muscle fibers.
Okay.
The collagen and elastin in your dermis naturally align to accommodate the repeated contraction of those muscles over a lifetime. Because of this structural alignment, the skin is about 3 times more distensible.
Meaning it stretches more.
Right, meaning it can stretch 3 times further when you pull it perpendicular to those STLs compared to pulling parallel to them.
Oh, wow.
If an incision runs parallel to the tension line, the wound edges naturally want to fall neatly together. But if you cut across them, the resting tension of the skin will constantly pull the wound open, which leads to a widened, highly visible scar.
Navigating this map also means knowing where the structural landmines are hidden. We see specific warnings about danger zones and free margins.
The temple is perhaps the most classic danger zone. Beneath the surprisingly thin skin of the temple lies the temporal branch of the facial nerve, tracking right alongside the superficial temporal artery and vein.
So it's crowded under there.
Very. The tissue buffer there is minimal, making them highly vulnerable to inadvertent injury. A careless millimeter in the temple can actually lead to a patient permanently losing the ability to raise their eyebrow.
That is terrifying.
It is. Then you have to consider the structural integrity of free margins. The lips, the eyelids, the nostrils, the helix of the ear.
Because unlike the skin on your cheek, they aren't anchored firmly on all sides. They are terminating skin edges separated by an open cavity. So what happens physically if a surgeon miscalculates the tension near one of those free margins?
If the closure creates excessive tension near an eyelid, for instance, the surrounding skin will act like an over-tightened drumhead. It will physically overpower the medial and lateral canthal tendons holding the eyelid in place.
Yikes.
Yeah, it pulls the delicate tarsal plate away from the globe of the eye, effectively turning the eyelid inside out. That condition is called an ectropion. On the lip, a similar tension failure is called an eclabion. This is a severe functional impairment. An eye with an ectropion cannot close properly, exposing the cornea to the air, which rapidly leads to desiccation and severe corneal ulceration.
Speaking of severe eye damage, that brings us to the immediate preoperative preparation. We have to sterilize the canvas, so to speak.
Yes, pre-op prep is vital.
The universal standard in most hospitals is a chlorhexidine scrub to eradicate surface bacteria. But the literature issues a massive warning here for dermatologic surgeons.
Chlorhexidine is a remarkably effective broad-spectrum antiseptic for the trunk and extremities, but it is highly toxic to certain delicate tissues.
Like the eyes.
Exactly. If it inadvertently pools into the eye, it causes chemical burns resulting in severe corneal ulceration. And if it drips into the ear canal of a patient who happens to have a perforated tympanic membrane, it can penetrate the middle ear.
Wait, really? What does that do?
It causes profound inner ear damage and irreversible sensor and neural deafness. In those specific head and neck regions, surgeons must pivot to safer alternatives like povidone iodine, assuming the patient has no iodine allergies, of course.
Okay, so we've mapped the face, we've navigated the danger zones, and we've prepped the skin safely. But I have a practical clinical question that always seems to cause panic in general surgical settings.
Sure, what is it?
If a patient requires an excision and they are actively taking blood thinners, like aspirin or warfarin, for an underlying cardiovascular condition, don't we have to halt those medications days in advance so they don't hemorrhage on the table?
Well, what's fascinating here is that the conventional wisdom you'd see in major orthopedic or cardiac surgery is entirely reversed in dermatologic surgery.
Really?
Yeah. Medically necessary aspirin and warfarin are rarely, if ever, discontinued for routine cutaneous procedures.
You just proceed while their blood is therapeutically thin? That sounds so risky.
The literature dictates a strict risk-benefit analysis. The statistical risk of a patient suffering a catastrophic thromboembolic event like a massive stroke or a myocardial infarction because you discontinued their prescribed anticoagulant far outweighs the risk of localized cutaneous bleeding.
Because cutaneous bleeding is manageable.
Exactly. A skilled dermatologic surgeon anticipates the oozing and manages it with meticulous technique, sustained pressure, and targeted electrocautery. You simply do not risk a patient's life for the convenience of a slightly cleaner surgical field.
Here's where it gets really interesting, though. We have the patient prepped and safely on the table. Now we have to select the instruments. Because choosing gear in derm surgery is remarkably similar to a golfer selecting the right club for a specific lie.
That's a fun way to look at it.
You wouldn't use a putter into the deep sand trap, and you wouldn't use a massive truncal blade for a delicate eyelid biopsy.
Right. The instrumentation is highly specialized because, again, the tolerances for error are microscopic. The absolute foundation of the tray is the scalpel, and the variations are highly specific to the tissue architecture.
So what's the go-to?
The primary workhorse of dermatologic surgery is the number 15 blade. It features a small, gentle, continuous curve that makes it perfectly suited for the vast majority of simple excisions and precise rotational turns on the face.
But not everywhere, right?
Correct. If you are operating on the back where the dermis is incredibly thick and highly resistant, that delicate number 15 might drag, snag, or even bend under the necessary pressure. That is when you must transition to a number 10 blade.
The number 10 has that much wider profile with a really pronounced convex belly. It's built structurally for sweeping smoothly through that dense, fibrous truncal tissue.
And contrasting both of those is the number 11 blade, which has a completely different geometry.
Yeah.
It's perfectly straight along the cutting edge and tapers down to a razor-sharp triangular point.
So you don't slice on that one.
No, you generally do not slice horizontally with a number 11. You wield it in a vertical stabbing motion. It is engineered specifically for piercing tissue to drain a cyst or abscess, or for executing incredibly sharp, precise right-angle cuts where a curved blade would invariably leave a jagged, overriding corner.
Okay, let's talk about the instruments used to put the tissue back together.
Yeah.
The text specifically highlights the Olsen-Hagar needle driver.
The needle driver is the robust, clamp-like instrument the surgeon uses to grasp and drive the curved suture needle seamlessly through the dense dermis. The Olsen-Hagar variant is a unique hybrid engineering solution.
How so?
Positioned immediately behind the jaws that grip the needle, it features a built-in pair of cutting scissors.
Which means a surgeon can throw a stitch, secure the knot, and instantly cut the excess tail of the thread without ever having to put the instrument down, reach for separate scissors, or rely on an assistant.
Exactly.
That level of efficiency must save a massive amount of time over a long procedure.
It is exceptionally efficient, but it introduces a notorious learning curve for young surgeons. If a resident isn't hyper-focused on their grip pressure while manipulating the instrument to tie complex, delicate knots, they can accidentally engage that scissor mechanism.
Oh no, so they cut the knot.
In a fraction of a second, they can inadvertently snip the masterfully placed deep suture they just spent 2 minutes securing. It is a very frustrating rite of passage.
I can imagine. We also see the curette mentioned constantly. It looks almost like a tiny melon bowler with a sharp circular loop at the terminating end.
The curette is a brilliant instrument because it provides profound tactile feedback. It is primarily utilized to debulk tumors or scrape away superficial benign lesions.
And you hold it differently, right?
Yeah, the technique requires you to hold it like a pencil, not a knife. You draw it toward yourself, scraping the sharp inner edge across the tissue surface. The brilliance lies in the pathology of skin cancers like basal cell carcinoma.
How does the cancer feel different?
These tumors are highly friable, meaning they are structurally soft, mushy, and crumbly compared to the dense, fibrous, normal collagen surrounding them. The surgeon can actually feel the microscopic difference vibrating through the handle of the instrument.
That is wild.
It is. The tumor yields easily to the curette like butter, while the healthy margin actively resists it.
That tactile differentiation brings us directly to the diagnostic foundation, the biopsy. Choosing exactly how to sample a lesion dictates everything that follows. We have punch biopsies, which are basically core sampling tools.
Right, similar to what geologists use.
Yeah, designed to capture a perfect vertical cylinder of tissue containing the full architectural strata of the epidermis, dermis, and subcutis. And then we have shave biopsies, where a flexible dermablade is used to simply slice off the superficial layers parallel to the skin surface.
And the clinical selection between those two tools is strictly dictated by the suspected pathology. If a clinician is examining a basic inflammatory rash or superficial basal cell carcinoma, a flexible shave biopsy is perfectly adequate.
Because they just need the top layers.
Right. The pathologist merely needs to visualize the cellular activity in the top layers of the epidermis and the superficial dermis to confirm the diagnosis.
But the textbook presents a massive, flashing neon warning sign when a clinician suspects a melanoma.
Absolutely. If melanoma is anywhere on the differential diagnosis, the clinician must always perform a full-thickness punch biopsy or a complete excisional biopsy. A superficial shave is strictly contraindicated.
Why is that absolute rule in place? I mean, if the goal of biopsy is simply to answer the question, is this cancer or not, wouldn't a shave give the pathologist enough cells to make that call?
Well, a shave will certainly confirm the presence of melanoma cells, but it fails to answer the most critical prognostic question.
Which is?
How deep does the tumor penetrate? The single most vital metric for a melanoma, the number that dictates the patient's statistical survival rate, how wide the definitive surgical margins must be, and whether the regional lymph nodes require surgical extraction, is called the Breslow depth.
The Breslow depth.
Okay. The pathologist must measure the unbroken vertical depth of the tumor from the granular layer of the epidermis down to the absolute deepest invasive cell. If you perform a superficial shave biopsy, you will likely
The rest.
exactly, leaving the deepest invasive roots behind in the patient's body. You have irreversibly destroyed the tissue architecture needed to measure the true Breslow depth, potentially costing the patient their life through catastrophic undertreatment.
Wow, the stakes on a seemingly simple instrument selection are incredibly high. So, assuming we've correctly biopsied the lesion and confirmed the diagnosis, the next hurdle is getting the remainder of the tumor out, while ensuring the skin doesn't tear itself apart when we close it back up.
If we connect this to the bigger picture, the foundation of almost all cutaneous reconstruction is the simple ellipse.
Right, because you rarely just cut out a perfect circle around a circular mole. If you try to pinch a circular hole closed, the skin bunches up at the opposing ends.
Yes, creating these raised, ugly, puckered mounds of tissue, clinically called dog ears. To allow the skin edges to fold together flat and seamlessly, you have to stretch that circle out into an elongated, tapered football shape. That's the ellipse.
And executing a flawless ellipse demands absolute mastery of blade control. Going back to our number 15 blade, at the very tips, or apexes of the ellipse, the surgeon must hold the scalpel completely vertical.
At a perfect 90-degree angle to the skin surface, this biomechanical positioning ensures a clean, sharp, non-overlapping corner. But as they progress along the sweeping lateral curve of the ellipse, they must roll their wrist, dropping the angle of the handle down to about 45 degrees.
That angle adjustment allows the rounded belly of the blade to take over the cutting action, maximizing the sharpest and smoothest continuous surface of the instrument.
It creates a beautifully smooth, naturally beveled edge. However, once that football-shaped block of tissue is extracted, you cannot simply throw some surface stitches in and yank the defect shut.
It just won't work.
The physics of the tissue will lead to disaster. You must perform a critical internal release technique called undermining.
Undermining sounds slightly terrifying to a layperson, to be honest, but the physics make complete sense. This is when the surgeon inserts blunt-tip scissors or a scalpel horizontally underneath the edges of the wound, snipping away the fibrous septae that tethers the skin down to the underlying fat and fascia.
Right, you are systematically creating a floating, mobile canopy of skin entirely around the surgical hole.
Because the physics of cutaneous tension absolutely demand it. Skin is an elastic organ, but its tensile limits are strict.
Exactly. If you face a 1 centimeter wide surgical defect and merely yank those edges together with a surface suture, 100% of the closure tension is concentrated directly on that millimeter-thin line of thread.
Which sounds painful.
And damaging. Over the following weeks, that unrelenting tension will pull the forming scar wider and wider. In severe cases, the immense lateral pull causes the center of the healing wound to physically cave in while the edges flare out, creating a highly visible fishmouth deformity.
So how far out does a surgeon actually need to undermine to adequately release that lateral tension?
The established surgical rule of thumb is that a surgeon should undermine a distance outward that is equal to or up to double the short axis of the elliptical defect.
Okay, so for a defect measuring 1 centimeter across, the surgeon is actively undermining and freeing the tissue 1 to 2 centimeters in every single direction beneath the surrounding skin.
Exactly. That extensive undermining allows the skin canopy to slide laterally over the underlying tissue bed rather than being brutally stretched across it.
And once the tension is neutralized, the suturing begins. The textbook details several closure techniques, but the purse string suture is mechanically fascinating.
It's a very elegant application of mechanical advantage. Instead of sewing linearly from one side of the wound directly to the other, the surgeon takes continuous circumferential bites of tissue tracing all the way around the inner perimeter of a circular defect.
Like a bag.
Just like that. When the thread is finally pulled tight, it acts biomechanically identical to the drawstring on a bag, radially compressing the tissue and significantly shrinking the total diameter of the open wound.
The actual thread material selected is equally as critical.
Right.
Deep down in the fat and lower dermis, where the surgeon just released all that structural tension, they utilize an absorbable suture like Vicryl.
Right.
But on the delicate surface, to perfectly align the epidermal edges, they switch to a non-absorbable synthetic suture, like Prolene or Ethylon, which has to be physically removed a week or two later. Why the difference in materials?
It comes down to cellular chemistry and the body's inflammatory cascade. Deep absorbable sutures like Vicryl are composed of polyglycolic acid polymers. They break down over weeks via hydrolysis.
Which means water breaks them down.
Exactly. Water molecules essentially cleave the polymer chains apart, which causes a relatively mild inflammatory response compared to older enzymatically degraded organic sutures.
But it still causes some inflammation.
Right. Any breakdown process summons macrophages and triggers inflammation, and on the surface of the skin, inflammation is the enemy. It equals scarring.
Ah, I see.
Therefore, on the visible epidermis, we use inert, synthetic, non-absorbable sutures. They slide through the delicate tissue with microscopic friction and remain virtually invisible to the immune system, preventing the inflammatory response that would otherwise leave tracking marks along the scar line.
It really is a profound tissue engineering problem. But what happens when the surgical defect is simply too massive? When no amount of undermining is going to permit those edges to slide together without horrifically distorting the patient's facial features?
That's a tough situation.
When the simple ellipse fails, the surgeon has to engineer entirely new solutions, namely flaps and grafts.
These are the heavy hitters of advanced reconstructive surgery. To comprehend them, you have to focus entirely on vascular supply. The fundamental biological distinction is this. A flap is a piece of adjacent healthy tissue that is incised and physically rotated or advanced over to cover the defect.
But it stays attached somehow.
Crucially, yes, it remains tethered to its original anatomical home base by a pedicle.
It retains its own intrinsic umbilical cord of blood vessels, basically.
Exactly. Because it imports its own robust, uninterrupted arterial blood supply, a flap is incredibly resilient. It perfectly matches the exact color, dermal thickness, sebaceous quality, and hair growth pattern of the immediate surrounding area.
And a graft.
A skin graft, conversely, is completely severed from its host tissue. It is a free piece of skin harvested from a distant, hidden site, like the crease behind the ear or the supraclavicular area, and physically transplanted into the open defect.
So it has absolutely zero blood supply of its own when it arrives. It is entirely parasitic, completely dependent on the new wound bed to rapidly sprout new capillary networks to oxygenate it and keep it alive.
Which means the physiological rules for where a graft can survive are unforgiving. You can never successfully place a skin graft over bare cortical bone or bare avascular cartilage.
Because there's no blood there.
Right. Those tissues simply lack the dense capillary networks required to sustain the ischemic graft tissue. A graft must be placed onto a highly vascularized bed of exposed muscle, fascia, or granulation tissue. Otherwise, it will rapidly undergo necrosis, turn black, and die.
Through all of these complex reconstructive decisions, the surgeon is bound by a strict hierarchy of priorities. The text calls it the golden rule of reconstruction: function before form and form before cosmesis.
It establishes an unyielding clinical pathway. First, you must guarantee the physiological function of the body part is preserved. For example, the eyelid can fully occlude the eye. The nasal valve does not collapse upon inspiration. That is function.
Their form.
Secondly, you ensure the macroarchitectural shape and bilateral symmetry of the face are correct. That is form. Only when those two critical pillars are entirely satisfied does the surgeon focus on cosmesis, the fine aesthetic blending and minimizing of the final scar line.
When we discuss removing the complex tumors that necessitate these massive reconstructions, we have to examine the absolute gold standard of the field, Mohs micrographic surgery.
Mohs is undeniably a marvel of modern dermatologic surgery. It was engineered specifically for high-risk tumors, particularly those located in what we classify as the H zone of the face. The temples, the ears, the eyelids, the nose, the lips.
All the highly visible spots.
And anatomically constrained areas where tumors exhibit a notoriously high recurrence rate. Crucially, these are areas where a surgeon absolutely cannot afford to empirically excise an extra centimeter of healthy tissue just to guarantee clearance.
So how does the Mohs technique fundamentally differ from a standard traditional excision?
Well, in a standard excision, the surgeon cuts out the visible tumor along with an estimated margin of clinically healthy-appearing skin, sutures the defect closed, and sends the excised block to a remote pathology lab.
Right, and you wait.
Days later, a pathologist slices that tissue vertically, much like slicing a loaf of bread, and examines a representative sampling of those vertical slices under a microscope to see if cancer cells touch the outer edges. The glaring flaw is that they are mathematically only evaluating about 1 to 2% of the total true surgical margin.
Meaning a microscopic asymmetric root of aggressive cancer could easily be hiding entirely unseen between those vertical slices of bread.
Precisely. Most surgery systematically eliminates that blind spot. The operating physician acts simultaneously as both the oncologic surgeon and the evaluating pathologist. They excise the visible tumor, but they execute the initial scalpel cut with a deliberate 45-degree angled bevel.
Yeah, why the bevel?
This specific geometry allows the excised tissue to be physically splayed out and pressed completely flat onto a slide in the adjacent lab. Then, instead of vertical slices, the tissue is frozen, and horizontal microtome sections are taken of the absolute deepest and outermost peripheral edges of the entire tissue block.
So they're visually examining 100% of the true surgical margin.
A full 100% circumferential and deep margin evaluation. Furthermore, they utilize precise colored dyes to map the tissue to a corresponding diagram of the patient's face.
To know exactly where everything came from.
If the microscope reveals a cluster of cancer cells on the slide, the specific color of the ink immediately identifies exactly where on the patient's face that microscopic root is still anchored. The patient waits with the bandage, and the surgeon returns to the exact coordinates to remove just one more targeted millimeter of tissue only where the cancer remains positive.
Wow.
They repeat this highly targeted cycle until the margins are definitively clear. It achieves the highest oncologic cure rate in medicine, frequently exceeding 99%, while preserving the absolute maximum volume of healthy structural tissue.
I have to ask the obvious question, though. If Mohs is so incredibly effective, and it spares so much vital, healthy tissue, why isn't it the universal standard? Like, why not use Mohs for absolutely every single basal cell, squamous cell, and suspicious mole on the body?
It comes down to immense resource intensity and healthcare economics. Mohs surgery requires a physician who has completed highly specialized fellowship training integrating tumor biology, complex reconstructive surgery, and histopathology.
So it's very specialized.
Very. It requires a dedicated, fully staffed on-site laboratory, specialized histotechnicians, and it consumes hours of clinical time and equipment for a single case. To deploy those finite resources on a low-risk, superficial tumor situated on the middle of a patient's back, where a surgeon can easily and safely take a wider traditional margin without any functional consequence, would instantly paralyze the healthcare system.
Oh, that makes sense.
Mohs is strategically reserved for where its precision is anatomically and oncologically required.
Even with Mohs precision, bodies remain unpredictable. Let's look at the physical forces that emerge postoperatively. Complications happen.
Complications are an unavoidable statistical reality of surgery. The mark of an expert surgeon is the ability to anticipate, mitigate, and aggressively manage them. Two of the most frequent space-occupying complications encountered are hematomas and seromas.
A hematoma is an active collection of blood pooling and expanding under the sutured skin. A surgeon attempts to prevent this through meticulous intraoperative hemostasis, essentially buzzing every severed microscopic capillary with electrocautery before closing and applying a highly compressive pressure dressing.
Right.
But a seroma is completely different. It isn't active bleeding, it's a sterile collection of clear, yellowish, serous fluid. How does a seroma actually form on a cellular level?
Seromas are directly linked to the inflammatory cascade in surgical geometry. They occur when a surgeon fails to close dead space beneath the skin.
What do you mean by dead space?
If you extract a massive tumor and merely close the superficial epidermis without utilizing deep, absorbable sutures to physically tack the subcutaneous tissue layers back down to the underlying fascia, you leave an empty subterranean pocket.
Ah,
Because the traumatized tissue walls are not abutting one another, the normal signals that halt the inflammatory phase are delayed. The body's natural hydrostatic pressure pushes inflammatory transudate fluid into that empty void until it balloons outward.
and if those deep tissues aren't secured, the overlying superficial wounds might be placed under too much tension, bringing us to structural separation issues, dehiscence and epidermolysis.
Dehiscence is a catastrophic mechanical failure. It is the complete, full-thickness splitting apart of all the sutured wound layers, exposing the underlying fat or muscle.
How does that happen?
It typically occurs because the patient engaged in prohibited heavy lifting, massively spiking their blood pressure and biomechanical tension, or because the surgeon fundamentally failed to adequately undermine and release the resting tension prior to closure.
And epidermolysis.
Epidermolysis is a more superficial ischemic variation. It's when just the very top epidermal margins die, slough off, and separate. This frequently occurs because the superficial non-absorbable sutures were tied far too tightly, effectively strangling the microscopic capillary blood supply to the wound edge, leading to localized necrosis.
So what does this all mean? For the learner, it means that the surgeon's responsibility absolutely does not conclude when the final stitch is cut and the patient leaves the operating table. Anticipating the physical forces, optimizing the vascular supply, and managing the aggressive biomechanics of the healing wound over the subsequent weeks is equally as critical as the initial incision.
A truly successful surgical outcome is a prolonged physiological partnership between the surgeon's precise intraoperative execution and the body's postoperative inflammatory and healing cascades.
Which wraps up our deep dive beautifully. Let's review the massive amount of ground we covered. We mapped the intricate topography of the face, identifying the mid-pupillary line and the biomechanical logic of cutting parallel to the underlying muscle fibers along the relaxed skin tension lines.
We covered a lot.
We did. We analyzed the specialized instruments, differentiating the sweeping number 10 blade from the piercing number 11 and the tactile brilliance of the curette. We explored the physics of the ellipse, the absolute necessity of undermining to neutralize lateral tension, and the chemistry of absorbable sutures. We broke down the 100% margin valuation of Mohs surgery, and finally, the underlying pathophysiology of seromas and tension-induced dehiscence.
It is a dense, scientifically rigorous volume of information, but every single fact directly dictates how the tissue will respond to the trauma of the scalpel.
And to reinforce what you've learned today, we are not letting you go without a brief exercise. Here is your review question based on today's dive. What is the fundamental physiological difference in blood supply between a cutaneous flap and a cutaneous graft? And how does that difference strictly dictate the anatomical locations where you can safely place a graft?
Take a second to think about it.
The answer. A flap is advanced while retaining its own intrinsic blood supply via a connected pedicle. A graft, however, is entirely severed and has zero intrinsic blood supply of its own. Consequently, a graft must absolutely be placed onto a highly vascularized wound bed, like exposed muscle or healthy granulation tissue, and will universally fail in necros if placed over bare avascular bone or cartilage.
This raises an important question and almost philosophical thought as we conclude. We have just dissected the intense, exhausting complexity of this medical field. We spent decades mastering the invisible topography of facial nerves, the precise microangles of steel blades, the complex cellular biology of wound healing, and the unrelenting physics of tissue tension.
All to achieve the ultimate defining irony of dermatologic surgery.
Exactly. The hallmark of a truly masterful, technically perfect dermatologic surgery is that the surgeon becomes entirely invisible. You utilize all of that profound scientific knowledge, all of those agonizing micro-adjustments, to ultimately leave a scar so perfectly blended into a natural contour line, so meticulously devoid of tension, that it looks to the outside world as though human hands were never there at all.
The high-stakes microscopic dance, leaving no trace behind. Something fascinating to consider the next time you study the lines in the mirror. See you next time.